Good evening. I am so glad that you had the ability to join us tonight for what I hope will be a pretty stimulating and quite updated discussion about what we're dealing with currently in the current COVID pandemic. As in previous sessions that we have had, we urge you to put your questions in the chat. I'd like to make a personal request that you confine the activity to chat in the chat as questions, because we're trying to go through these so that we can answer them for you. And I'd appreciate no editorial debates, because it just makes it difficult to pick out the questions at this time. I would like to thank the Chicago Medical Society for making this educational opportunity to occur. We have a distinguished group of speakers tonight, and it's a little bit slanted towards my colleagues at the University of Chicago, which I'm also very thrilled to announce. But we're going to have Dr. Johnson from the Department of Pediatrics and Dr. Bartlett from the same department, and we'll be able to have Dr. Mullen, who is an ID expert and vaccinologist from the Department of Internal Medicine and Infectious Disease, and Dr. Vishnu Chundy, who is the chair of the COVID-19 task force, and the very distinguished infectious disease expert who's been available for these sessions since the inception. So with no further comments at this point, because we have a long agenda, I'd like to move forward with our first speaker.
Thank you, Ed. I wanted to talk about what's going on with COVID-19 and policy. The first slide is from this current issue of Science, and it goes over the various variants. And I thought this was very interesting because it looks at the timeline of when the original strain from Wuhan started out and where we are today, between the alpha, the beta, the delta, the gamma, and epsilon, theta. And it shows you how the virus has rapidly evolved. When I grew up, I was taught, that viruses tend to get less pathogenic, tend to want to live with you, and HPV and HSV were the classical examples where, these are long-lived viruses that have been around with us for a long time. Whereas we've learned that the viruses don't really read our textbooks and what we were taught in medical school. Here you're looking at a virus that has now become more pathogenic and more infectious. It's being borne out by the younger people getting infected, and now the recurrence of the Delta strain, which is wreaking havoc throughout the world. So I would urge you all to look at this article from Science, but today we're going to deal with the Delta, because Delta is the predominant strain right now, and it's changing the pandemic, and I think it has irreversibly changed this from something we could have controlled before to something that we're going to have to live with and kind of exist with, and have an acceptable risk that we're going to have to be around. Next slide. So this is in Science, and it goes over the hostile takeover of the variants, and you can see how it went from beta initially hanging out a little bit to alpha, which is essentially almost gone, gamma, and now delta predominating. Now there are new strains out there with more than 20 mutations that are still waiting in the wing, which will come on our shores, and I think we're going to see more and more of this as time goes on. And so get ready for a prolonged period of time. Do not think this is going to be over come Thanksgiving or Christmas. I think we have to have a mindset that we're going to deal with this for a long time, and we're going to have to learn how to adjust our viewpoint. Next slide. And this talks about the antigenic map of how the virus has drifted further from the Wuhan strain, with the beta strain being the furthest, and delta also changing, alpha being the closest to it, where the vaccines are more effective. So the further it goes away, and you can see Eta and Kappa in the wings out there that are further away from the Wuhan strain, which the vaccines were based on, and the fact that these vaccines are antibody-based vaccines. There's a lot of conversation and some study and some trials out there looking at vaccines that are much more T-cell based, and pediatric world knows, and those of us old enough to remember H flu coming through every winter, decimating kids with all the spinal taps that we used to have to do. You don't see that anymore because the pediatric world came out with a great vaccine that stops colonization of the bacteria in the throat. The same thing has happened actually with the brand name of Prevnar, which prevents colonization. And I think this is where it's going to have to head in the vaccinology world, where we're going to need vaccines that prevent, basically give you sterilizing immunity and prevent spread from one another if we're going to live with this virus for any period of time. Next slide. Quickly here. So our objectives are: what are the changes in the pandemic during this talk? What are the returns to school? And then booster doses. Next slide. So these are the daily confirmed cases, and the poignant part about all of this is Israel, because Israel has one of the highest vaccination rates, and you can see the daily confirmed cases are per million cases, over 800 cases per million people. So despite high vaccination rates, Delta has overcome this. Now, it does not mean that the hospitalization rates and the death rates are high like this, but it means that many people are getting infected. Okay, I think you have to be very clear about this. And you can see the United States and the United Kingdom are also increasing. The strange anomaly of all of this is India. India is way down low. And actually this morning I got on the phone and I called my relatives, and every Indian has remember the 6 degrees of separation? Well, Indians have 2 degrees of separation because every Indian is related to you within 2 degrees. And so I called up Delhi, Bombay, called up Chennai, called up Hyderabad, and all the physicians that I know out there, and they're not seeing much COVID anymore that are sick. I mean, you are having community transmission, but it isn't where they're admitting in the hospital. And so I think there are a couple of reasons for this that we're not going to get into in this talk, but India is kind of where, and it's a younger population. You have to remember, India is one of the youngest populations out there. So that may have something to do with the amount of reporting, and reporting is less in India. Next slide. And this is the this is a sobering setback of what happened. We had great newspaper articles about how you got the Israeli pass and you can go to concerts, you can hang out at restaurants, you can hang out at the health club. Well, not so quick. Delta has changed the conversation here. Next slide. And you can see the daily confirmed deaths per million. And you can see this slide of the United States going up, Mexico going up, and you can see Israel is also going up. So clearly the death rate is increasing. And so this is what we're headed towards right now. We're over 1,000 deaths per day. It's expected to peak at over 1,500 deaths per day. Florida itself today accounts for over 200 deaths. Next slide. So 33% of the world is vaccinated. 25% has received 2 doses of vaccine. 5 billion doses of vaccine have been given worldwide. Sound like Carl Sagan. 33.85 million doses a day are being administered daily, and 1.4. But here's the other part of it: only 1.4% of people in low-income countries have received a dose of vaccine. Next slide. And this is self-explanatory of where the vaccine is: Portugal, Qatar, and you can see in the bottom Tanzania, Nigeria, Egypt, Myanmar, Bangladesh, South Africa, Vietnam, and so you can see where the highly vaccinated countries are and the lower vaccinated countries are. And so this is how the world is shaking out. Next slide. This is from the New York Times of daily reported cases. You can see that the United States pandemic compared to August and November, the graph is eerily similar and it's very scary. Next slide. Cases by region. You can, the regions in the South, and you can look at Mississippi, followed by the West, followed by the Midwest and the Northeast. And this basically parallels where the vaccination rates are. Next slide. And the hotspots. This is for some of our members who are listening today who have gone to Florida thinking it was a great spot to vacation. Not a great spot to vacation. Great spot to catch COVID and get breakthrough infections. The same goes for Georgia, where we have a practice which is overwhelmed right now. Mississippi, Alabama. This is not, Louisiana. This is not a good place to be. Next slide. One thing on the previous slide, the hospitalization rates in Hawaii and Alaska are also going up. Now go to the next slide. The problem is in Hawaii, they're running out of hospital beds. It's not like you can go out and have a bunch of people go from Texas to Florida. And so Hawaii is as a crisis state right now. They have only less than 1,000 hospital beds, probably 800 ICU beds left. They're in deep, deep trouble with this. So they don't want any more visitors coming to Hawaii because of the hospitalizations. And Florida is completely overwhelmed right now, as well as parts of Texas. And you're going to see this happen in Southern Illinois. You're going to see this happen in an area wherever people are unvaccinated. Next slide. And one of the things, human behavior, humans like to live. And you can see where the rates are high, people's vaccination rates are going up because all of that hesitancy and all of that stuff is being conquered by watching people die. And that's not a good way to learn. We'd hope we have a frontal lobe and we have a processing facility that sets us apart, where we hopefully get vaccination at a higher rate. Next slide. Bad policy leads to bad outcomes. This is basically a case study of Florida. Next slide. Almost done, Ed. And you can see that the rates in Florida now exceed anything that's happened in the previous pandemic. The rates of death, the rates of hospitalizations, the rates of children getting infected. This is just unbelievably sad. Not bad, it's sad because all of it was unavoidable. Next slide. Was avoidable, not unavoidable. And this is the hot spots, basically, where all of Florida is a hot spot. It's just what is hot and what is hotter. And so I would tell anyone who wants to travel to Florida, please don't go there right now. Next slide. This is Illinois Region 11, where we are. Our rolling 7-day average is just under 5%. Next slide. And our ICU beds are getting near that threshold of 20%. It depends on where you are in Chicago. We go to hospitals where we have 5-6 patients, and small percentage of beds occupied with COVID patients. And we go to other hospitals which are getting hit very hard, and it depends on the vaccination rates in those places. And these are all involved with collar counties. Next slide. I think we're done. So I will leave this to Dr. Bartlett, who's a pediatric infectious disease and epidemiologist. And I welcome Dr. Bartlett because this is a very important topic about what happens with pediatric illness. And Ed, can you, anything else to? Go ahead, Dr. Bartlett.
Absolutely. Thank you for allowing me to come speak. I've been speaking a lot about this. I have personal and professional interests. I have 3 sons who are under 12. Although my twins will be 12 in October, and they are going to start their in-person school next week. So I'm living this along with all of you. Next slide. So I have a couple of demographic slides here as well of what is going on with COVID in kids. We're definitely seeing a lot more cases in kids than we have in quite a long time, owing to the fact that they are out and about and their relatives are out and about and getting infections. It does not appear to be more severe. It's just a small percentage of an increasingly large number of children. The next slide is unfortunately my unformatted slide that snuck through, but apologize for the poor formatting. These are the death rates in children, which, as Dr. Johnson mentioned, we just hit 400. But if you look over time, you can hardly see on the graph where the children's lines are. But rates of death are from 0 to 0.04 per 100,000. But again, that's just not an acceptable thing for us as pediatricians to be seeing at all. And so we are paying close attention to that. Next slide, please. Again, death is a really rare outcome, which is good, but what we are seeing is rates of hospitalization that are going up and up and up. And this is much more kids who are sick with COVID, as opposed to very early on in the pandemic, when we were having kids come in for appendicitis or other things that happened to be found to be COVID positive. We're having much more symptomatic kids. But again, when you compare it to all age groups, where it's hardly a blip. but every child is important. Next slide, please. The most recent data overall is that in the week before last, there were 180,000 pediatric cases, which was 22% of all the cases. Pandemic-wide, the average is about 14% for kids of all cases, so significantly overrepresented recently. Again, data are sparse on hospitalization. Only a few states report this, but somewhere between 0.2 and 2% of kids, which again, 2% of a very large number will be a very large number. And as Daniel mentioned, the death data has been updated, but it is a significant number for us. Next slide, please. This graph talks about MISC, so the multisystem inflammatory syndrome in children that happens post-COVID, which is in the blue line and follows about a month after COVID cases, which is the dotted black line. So we have not seen up in the Chicagoland area an increase in our MISC cases, but we fully expect to see a surge of that as well coming soon. There have been over 4,000 cases reported in the country, and again, 37 deaths, which is not included in the other COVID numbers. Next slide, please. And it's not just COVID. So this graph shows the winter of 2019 RSV peak, and then the amazing winter of 2020 where all kids were home and everyone was socially distant and there were masks out in public and nobody got RSV. And then about April, things started loosening up and RSV is back. It is back. We've got 2 birth cohorts of kids who've never had their first infection, which is more severe than subsequent infections. We have, 1-year-old airways are not that much bigger than newborn airways, so they still have a lot of the complications. We're also seeing more serious cases in school-aged kids and older. And I can't help but wonder if the fact that they weren't in school, didn't get a cold, which was their sort of RSV booster shot, right, last year, is leaving them in a slightly less prepared status for immunization or for response to the virus. Next slide, please. And then we're seeing parainfluenza. It's hard to read this. Parainfluenza type 1, we're still at less than 0.1% positive, not a big deal. Next slide. Type 2, we're at 1.5%, but then type 3, next slide, is off the charts. It's 16% sort of positivity, more or less, depending on how you look. So we are seeing respiratory illnesses from COVID and RSV and paraflu and rhinoentero, and the pediatric hospital epidemiologists have a little text chat group, and we are sort of having a competition to see who's going to be the first one to 5 positive viruses on someone's respiratory panel, because we are definitely seeing a lot of co-infections. Next slide, please. And to that point, we don't know what the impact of co-infection is going to be. I can't speculate that it's going to be a good thing. We just didn't see co-infections earlier on because, again, our kids weren't getting COVID because they were protected and they weren't getting RSV. So now we have populations that are vulnerable to both of these, and it really is overwhelming the pediatric intensive care sort of hospital system across the country. Just like on the adult side, worse in the South, but it's coming our way. Next slide. I wanted to talk briefly about pediatric COVID vaccinations. Again, personally and professionally very much interested. The Pfizer vaccination was approved with an EUA back in May. We have 43% of teenager or 16 and 17-year-olds and 33% of 12 to 15-year-olds fully vaccinated. That's not enough. Moderna data has been submitted. It's approved in the UK for the younger age group. And there was I don't remember if it was New York Times or Washington Post article earlier this week about whether it's the concern about an increased risk of myocarditis with Moderna compared with Pfizer that is holding this up. But again, 8 per million versus 20 per million doesn't seem clinically appreciably different. We do now have full approval for Pfizer, but lots of groups, AAP, CDC, everyone's saying, don't go using this off label. We will have data, it's a dose de-escalation study. I have no doubt that the vaccine is going to work very well in kids, but we could probably get away with a lot less antigen, vaccinate more people, and not have such severe side effects in our kids. So they're looking at, instead of 30 micrograms like for adults, 10 and then 3 for the younger age groups. I was super optimistic in June that we would be starting in September with kids. I get discouraged every time I see Dr. Fauci talk about where we are. Is it going to be in the middle of the fall? Is it going to be December? Is it going to be 2022? I don't know. It's not going to be soon enough. And once again, we haven't prioritized kids in how we're managing the situation. Next slide, please. I think this is my last slide because I definitely want to leave time for questions at the end. This came out yesterday or today in the New England Journal. This is a publication out of Israel, which looked at their sort of relative and then here absolute excess at risk of a variety of things, comparing whether you had a COVID vaccination in blue or a COVID infection in yellow. So, the first thing that jumps out in terms of vaccination is lots of lymphadenopathy, which doesn't surprise us at all. Many people get that, it goes away. That's fine. That's great. I'm excited that that's the big deal. The thing that I included this to focus on is the myocarditis piece. There is an absolute increased risk of myocarditis with vaccines. Again, this is in 16 and over population, so we don't have any data on the younger kids. It was 21 cases, mostly in 91% were male, median age was 25, exactly what we would expect. So 21 cases, but these are all, again, sort of self-limited, sometimes lead to admission, supportive care, and they get better, as opposed to the very real and much more severe myocarditis, pericarditis that's associated with actual COVID infection. So I think this is going to be some data that I will be sort of bringing up in our conversation with families who have concerns, appropriate concerns about the risk of myocarditis in their kids. I think that's my final slide. I see a couple of questions coming in. Would you like me to wait until the end to sort of answer those?
Yes, we're going to try to answer them as a group in the end.
Okay, perfect.
Thanks, Allison. It's my turn now. Next slide. You can see I'll be talking about COVID in schools, and Allison, Dr. Bartlett did such a great job with presenting data that I'm not going to do this slide, so we'll skip this slide. Yeah, we can skip the next slide too. And really go on to recommendations. Both Doctors Chundy and Bartlett got to raise your anxiety level, and hopefully I get to lower it a bit, given the conversation that I'll talk about in terms of, well, what's the solution here? We don't want our kids getting COVID, and happily, we live in the state of Illinois that seems to be taking a more rational approach to how we're going to handle schools and kids. And of course, the first thing is promoting vaccination. We know that if we surround the unvaccinated with vaccinated people, that we're going to reduce the risk of spread. Even though the vaccine isn't perfect against Delta, it still works quite well against Delta, right? I mean, we're talking about a 60 to 65% rate of preventing infection. We would have been pleased as punch if that's all we had gotten from the vaccines. But because we started out at 90 to 95%, We look at that 65% or so rate of effectiveness and we go, oh dear, but man, that would have been great news a few months ago. And then we look at its efficacy in terms of preventing serious disease, hospitalization, ICU, and we're talking in the 90% range. Really, it's a great vaccine, and the best way for us to prevent spread to kids starts with vaccinating everybody that's around them. And as of today, I got an email at 3 p.m. this afternoon that was the recommendation, the rule put out by our governor that requires all school personnel to be vaccinated. And it's a very directed order. By 9/6, everybody who works in schools must have received at least one dose of a 2-dose vaccine or the 1 dose of J&J. And they must have the 2 doses if they got the mRNA vaccines by 10/6/2021. The only exceptions are going to be religious or medical. And it's hard to come up with a medical reason not to give people the vaccine. Really hard to come up with that one. So I hope those that are listening today recognize that, because you're going to have patients come to you saying, oh, I need a medical reason not to get this vaccine. And I hope that you will tell them what they need to hear, which is there really isn't a medical reason not to give this vaccine. I suppose anaphylaxis, but even allergic reactions to the first dose doesn't appear to be a good reason to not give the second dose. So please vaccinate. And for those people who are not fully vaccinated, or those who have this rare exception, then they're going to have to get weekly COVID testing in order to work in our schools. I think this is a good outcome. Next slide. So what else? There's a mask mandate. Now that mask mandate came out by the governor at the beginning of August. Masks are required indoors in schools by all individuals greater than 2 years old, regardless of vaccination status. That's universal indoor masking. In general, people don't need to wear it outside, but CDPH and IPH have made the recommendation that if you're going to be in a crowded setting, go ahead and use a mask. Passengers and drivers must wear a mask on all school buses. Next. So pediatric providers may determine that a child is medically unable to tolerate a face mask. Here are some reasons. Difficulty breathing at rest. So it's not people with asthma, or at least most asthma, unless it's being mismanaged. So the good news is in terms of recommendations, is that really there's almost no reason for a child not to wear a mask in school. If the child is developmentally disabled, such as they're unable to remove a mask, then that's a reason to consider giving them an exemption from wearing a face mask. But most of those individuals could wear a face shield instead. Now, if they're wearing a face shield, the recommendation is instead of separating them by 3 feet to 6 feet from others, they should be separated by 6 feet from others. And why is this so important? Well, it's so important because we know that masking is incredibly effective at preventing spread of SARS-CoV-2. And so we want our kids masked in school. We want the people around them masked. And if there are very few exceptions, well, then we're protecting our kids. And that's what we want to do. Vaccinate them, protect them by masking. Next slide. Children with asthma and other chronic respiratory conditions should wear a mask unless they have such severe difficulty breathing at rest. So again, you're going to have families come to you because they're just like they're anti-vaxxers, they're anti-maskers. They're going to come to you and they're going to ask you to sign a letter that says, oh, my child should not have to wear a mask. Well, I hope you'll resist, because there are very few reasons why a child should not wear a mask in school. Next slide. And, you know, if a child's anxious about it, they can use behavioral techniques in order to learn how to manage wearing a mask. And I can tell you from experience, as well as the reports of others, that it's possible to train children down to age 2 to not only wear a mask, but even, in fact, be uncomfortable if they're not wearing a mask. So please resist the urge to write those letters to make a child exempt. Next slide. Physical distancing, I thought we'd just review it for a few minutes. Greater than or equal to 3 feet. There is a wealth of data that shows that in school settings that you don't need 6 feet, 3 feet is more than enough. Particularly in the setting where it's a classroom, where everybody's facing forward, or individuals are wearing masks. Now, when it comes to food and eating, of course, people have to take off their masks. And so the goal at schools should be to spread people out. All doable things. And this is the approach that we need to take. Next slide. The other things to encourage, of course, is good hand washing. Even though there's not much spread off of hands, there still is some. And it's pretty easy to get kids to wash their hands, send them to school with a bottle of hand sanitizer, recommend that they wash their hands. For respiratory etiquette, we all know about needing to cough into your elbow. Kids are really good at it. You want them not to be covering their mouths with their hands, but to use that arm and elbow. Next slide. Routine cleaning is all that's needed. So schools can put their energy into the need to wear masks, hand washing, and respiratory etiquette, rather than have to spend resources on over cleaning, which we've discovered really doesn't make that much of a difference. Next slide. And then cohorting is something that makes sense still, although many schools have moved away from it. But I would urge that in settings where there's moderate to high transmission, to continue to consider cohorting as one way to reduce risk of exposure. Next slide. Screening. So we do know that screening works. Screening by testing, but there's no reason to test people who have been vaccinated. And so schools will end up picking and choosing in terms of how they approach the decision about screening. Next slide. People who are fully vaccinated should not participate in screening because their likelihood of being infected is so low that they're much more likely to have false positives. In fact, if you look at the predictive value of people who've been vaccinated, it's low enough that it makes no longer sense to do screening testing. Only makes sense to test them if they're symptomatic. Next slide. Ventilation. This is, of course, remains valuable in the school setting. You can see from these many different pictures that keeping the windows open as long as you can is valuable in terms of improving ventilation. And then use of a fan, but please note the arrows. The air is going out, not in. And the goal there is just to move air out so that way you reduce risk. Now, HEPA filters may be of help with clearing a room that's been contaminated more quickly, but it's unclear how effective it is in real time. So HEPA filters still are a question mark. But opening windows, even one window, makes a huge difference in terms of movement of fresh air in. And the use of a fan certainly helps with moving air out. And the picture of the bus is to demonstrate that having the windows open on a bus will move air and reduce risk of harm. Next slide. So what do you do if there's a case in school? Well, first, we should define what a close contact is. And a close contact is an individual who's not fully vaccinated, who is within 6 feet of an infected person for a cumulative total of 15 minutes or more over a 24-hour period. For students in a classroom setting, contacts who are within 3 to 6 feet of an infected student do not need to quarantine if the case and the contact are consistently masked. So this is a change from how we were defining contacts early on in the pandemic, and is a very important one for all of us to be aware of. And then if there was just exposure in an outdoor setting, that also is not considered to be a close contact. Fully vaccinated people who remain asymptomatic and those who had a proven case of COVID-19 infection within the past 90 days are excluded from quarantine. So what to do if there's a case in school? First, make sure that we understand what is a close contact. Recognize that if you're vaccinated and you remain asymptomatic, you do not come under the header of needing to quarantine. Next slide. So how to handle those individuals who don't fit under those criteria. So an individual who was exposed in school, there wasn't use of proper masking, or in the setting where there was not vaccination, well, then you have a few options. Option number one that the school can use is just quarantine 14 calendar days. Option number two is to quarantine for 10 calendar days. And if there's no symptoms during daily monitoring, there were never any symptoms developed, then allow them to come back into school, but of course, maintaining physical distancing and masking at all times. 7 calendar days would be, again, something that could be considered, but it's not clear to me that 7 calendar days should be used unless there is a documentation of a negative test that occurred on day 6 or after. Next slide, which should be my last slide. So it's option number 4, which I think a lot of schools are going to make use of, which is a test to stay strategy. That if the exposed individual is being tested on days 1, 3, 5, and 7 from the date of exposure by a quality test, that if they're negative, then as long as they're asymptomatic, they can stay in school. This is one way to increase the number of kids who stay in school, which is something that we definitely want to try and maximize as much as possible. Because what we've learned from the pandemic is being out of school is bad for kids. It's bad socially, it's bad educationally. And so anything we can do to keep kids in school is worth doing. And this test to stay strategy is a great way to reduce risk by doing the testing as proposed there on days 1, 3, 5, and 7. Now, if you pick up about exposure late enough that you can't test on days 1 and 3, as long as they've been asymptomatic and you're doing the testing out on days 5 and 7, you're fine again with keeping that child in school. But again, they have to wear a mask that's well-fitting so that way if they end up developing symptoms, that the amount of exposure they've done is minimized. I think that's my last slide. So we'll move on to Dr. Mullen.
Hi. So I wanted to show a little statistics of where Chicago is and how the epidemic is changing. And as you can see at this point in time, Delta right now is, we don't test every strain, but of the strains that are tested, Delta now accounts for 98% of the strains in Chicago. Next slide, please. So we're hearing a lot about boosters, who should get them, when should we get them? So I'm just going to go through a little bit of the data that we have thus far, and there's certainly a lot more that needs to be done to establish this. So August 18th, the US announced that they were planning to offer boosters to everyone who'd been vaccinated more than 8 months ago. And it was felt that this was going to be an offensive move in advance of winter to try to decrease the likelihood of people getting COVID. And the idea is to protect against infection because our antibody titers are waning, and we want to get our levels up as Delta is spreading. The idea is to begin around the 3rd week of September. It's still going to be free. 80,000 sites nationwide will be delivering the drug. And at this point, you still need to bring in your ID card that shows that you've had the vaccine already. You need no insurance, no state registry requirements, or any other ID. It'll be for adults aged 18 years and older. And it can be a 3rd dose of either Moderna or Pfizer. Does not matter which one, and we'll show why. And then teens are not going to be included until December, obviously, because they didn't start getting vaccinated until April or June. So thus far, only Pfizer and Moderna recipients are going to be getting their 3rd dose, not Johnson & Johnson, because the data is upcoming. We do have some data from Ensemble 2, which is the J&J double dose vaccine. But as we'll see, it doesn't really matter which one you dose with, but if you have a adenovirus vector vaccine first, you're going to get better titers from an mRNA vaccine following that. So next slide. So why? There's a huge argument going on. Why a booster? Do we need it? Is it equitable? So we know that the immunity that's triggered with SARS vaccines wane over time. You see an initial surge of antibody titers, a slow drop, and then there's a pool of memory T and B cells. And when we give boosters or you're exposed to COVID, then those B cells begin to multiply, and you have a larger pool of memory cells and a higher antibody titer. And so each time that you are exposed to antigen, you get a faster and stronger subsequent response. And you also get enhanced antibody binding because with the increase in the B cells, they're processed, and there's some mutations that go along with our own antibody titers. And so we may see enhanced potency with the antibodies as life goes on. So, but isn't that true for all vaccines? Well, yeah, all of our vaccines, when we get dosed, we see waning titers, they drop, and then we have protection. So does this drop in antibody titers equate to decreased protection in SARS-CoV-2? Well, we don't know, because we don't know what the magic number is for correlation of protection. And so that leaves us only with clinical correlates, and our canaries have been our patients who were in our studies and those who were in the phase 1 trials as well, who are the earliest ones who were vaccinated. And the question is, are those people who are vaccinated, are they at increased risk for getting COVID disease or not? And so the World Health Organization in August 4th said, no, we should not be giving anybody a third dose. We're wasting resources that are protecting people against severe disease. We know that the UAE, China, and Russia are already boosting. Israel and Germany have planning and have started instituting in their high-risk patients boosting. And certainly the US already approved boosting in our immunocompromised people. And as I said, by the third week of September, it's planned to start boosting everybody. Next slide. So do the current vaccines that we have, are they giving us, or the preformed antibodies that we have, are they protecting us against the variants? So next slide. When we look at data from England, the vaccine is effective against Alpha and Delta variants, according to the dose and the vaccine type that they've given. So if you look at the adenovirus vaccine, which is the CHAd OX1, the Oxford vaccine, and the Pfizer vaccine, or any vaccine given, we see that a second dose certainly gives better immunity against Delta and Alpha than a single dose alone. And so we know that we need to have 2 doses of vaccine to have efficacy and not just one. Next slide. It doesn't matter if it's Alpha, Delta, or whatever other variant that we have. And again, so when we look at a single dose for any vaccine, it's about 31% effective. For 2 doses, we're in the 80 range, higher with the mRNA vaccines compared to the adenovirus vaccines. Next slide. And what about efficacy for the variants that we're seeing now? And this looks at neutralizing activity of serum against the initial Wuhan virus, as well as the variants, looking at our phase 1 patients, taking their serum and then looking at efficacy or 50% neutralization against the SARS vaccine or SARS virus. And we see just a small 2 to 3-fold fall in a reduction in our neutralization with the Delta variant around 2.1, Gamma 3.2. But with our Beta variants, or the we see even higher than that, up to 8-fold fall in our neutralization titers. Next slide. And how about for our preformed antibodies? We know that bamlanivimab has lost its activity. It needs now to be combined with etosidomab, and then the combination product from Regeneron as well has held activity against Delta virus, less so with the casdatifan for the Beta virus. Next slide. What about using different ideas of who should be vaccinated? So when we look at our patients who were previously unvaccinated and had COVID, we see that a single dose of vaccine in those patients markedly increases their titers, even higher than giving a second dose of vaccine to our patients who were vaccinated but not having an infection. So having had COVID infection in the past really boosts or allows a big boost in antibody titers compared to just our vaccines alone. Next slide. So do the vaccines need to be from the same platform? Next slide. No, but we do know that if someone has an adenovirus vector vaccine and they get a second dose of adenovirus vector vaccine, that their responses are not as good as someone who has an adenovirus vaccine with an mRNA vaccine, or people who get 2 doses of an mRNA vaccine. So it looks like if you got an adenovirus vector vaccine and you get then an mRNA boost, that you should have titers that are pretty similar to someone who gets both mRNA as their primer and their initial boost vaccine. Next slide. And this again shows that if you have the adenovirus vector vaccine, that it's not going to give you the high titers that you would like to see compared to the mRNA vaccine. So I think no matter what the Johnson & Johnson data is going to say for Ensemble 2, that probably it's better to get an mRNA vaccine on top of that. Next slide. So this is looking at reactogenicity and immunogenicity in people who have received the first dose of the adenovirus vaccine, and then they get a booster dose with the mRNA vaccine. And as you can see, from their baseline to out to 14 days, their titers end up being much higher after a mRNA boosted. And they have very acceptable reactogenicity, meaning that the side effects that go along with the vaccine are not really higher than what they were with the second dose of vaccine. Next slide. And this again shows those people who've had a history of infection versus those who have not had a history of infection, looking at not only their B cell responses, but their T cell responses. And so we see much higher T cell responses in those people who have had an infection in the past compared to those who have not had an infection in the past. Next slide. What about breakthrough? So this is the whole idea of why do we need booster vaccines? Next slide. So I showed this last time. This is the data from the UK and from Israel looking at Delta virus causing infection in people who have had vaccination. So if we look at the UK data, symptomatic disease after 2 doses is still markedly reduced with Delta, although 33% if you only have 1 dose, and hospitalizations still significantly reduced with a single dose, and as well significantly reduced with 2 doses. In Israel, they didn't see as nice a protection. So when we look at June, where a much higher amount of Delta was present in Israel, they noted, from June 20th to July 21st, where there was a predominance of Delta in Israel, the efficacy fell for both prevention of infection and symptomatic disease, and as well for hospitalizations, although hospitalizations not as much as just symptomatic disease. The mRNA data is out or is completed, has not been published to the point that it can be viewed yet. It's still confidential with Moderna. So next slide. It's been submitted for publication. So what about, this is a study that was from Minnesota that looked at mRNA vaccines and efficacy. And one thing that really wasn't noted in this is that there was about a month difference in start dates of giving people vaccines between Moderna and Pfizer. So we're actually looking at people a little bit further out from their vaccination in the Pfizer group compared to those in the Moderna group. But what they saw was that with the Pfizer vaccine, from January to July, there was about a 76% incidence of effectiveness of the vaccine against people getting SARS-CoV-2 versus 86% with mRNA vaccine. But in July, when there was a big shift in the amount of Delta virus that was present, they saw a marked fall in the Pfizer vaccine's efficacy compared to that of the Moderna vaccine. And again, I'm not sure that this is truly vaccine failure, or that we're seeing people further out on the Moderna or on the Pfizer vaccine compared to the Moderna vaccine. But again, the hospitalization rates in those who were vaccinated are still low for both, although it did fall when we saw the Delta virus taking over. And then prevalence of SARS-CoV-2 variants in Minnesota, we see that the alpha virus was the predominant one until getting closer to the early summer and through summer. And now Delta is the #1 variant that's there. And interesting to see on the left-hand side, hospitalizations of those who were in the placebo arm or who were unvaccinated, essentially, for hospitalized people in the state of Minnesota compared to those who were vaccinated. And when you hear Delta Airlines talking about vaccination in their employees because they're self-insured, every patient who gets hospitalized who's an employee from Delta, it's about $50,000 per hospitalization that Delta has to come up with. Next slide. So a huge cost to our healthcare system. AstraZeneca as well has a better efficacy with 2 doses versus 1. So 60% against symptomatic disease in people with 2 doses versus 33% after 1 dose, and 93% efficacy against hospitalization after 2 doses, 71% with 1. J&J, they do have their 2-dose data available from the UK, 79% efficacy against symptomatic disease with 2 doses, 35% after 1 dose, and 96% efficacy against hospitalizations after 2 doses, and 80% after 1 dose. Next slide. So what about boosters? Are they effective or not? We don't know. Next slide. We don't know if they're effective or not. All we can tell you right now is that we see higher titers of antibodies, and so we equate that as efficacy. So this is on the Pfizer's website. It's their second quarter data for their presentation for investors, and they looked at, or this is the data that they presented there, of patients who were dosed 6 months after their second vaccine. The tolerability or immunogenicity of the vaccine was no different in the group that got their 3rd dose compared to the 2nd dose, and they did see marked increases in antibody titers, and significantly, there were nice titers in the group of patients who were over 65, equating almost to those who were less than 65. And next slide. And so they also noted that in the wild type virus, with the 3rd booster, they saw a 5 to 8-fold rise in neutralizing antibody titers. Those against Delta virus, they saw a 5-fold increase. And again, significantly in the elderly population with the 3rd dose compared to the 2nd dose, they had a 11-fold rise in titers of neutralizing antibodies with the 3rd dose. Next slide. Okay, and that's it. The Moderna data looks very similar. It was presented to us at the vaccine meeting, but it was still confidential on the numbers. But again, the adverse events were very similar to what was seen after the 2nd dose, and the jump in antibody titers is significant as well. The other thing that was interesting with Moderna is that there was no benefit in looking at specific antibodies for the variant mutations compared to the standard mRNA 1273 vaccine. They look equally effective, so they're not going to go forward with the variant vaccines at this point in time because it doesn't look like the titers are going to be any better. Thanks.
Thank you, Katie. Dr. Lynn's connection cut out, so we're going to go a little bit long because there were questions. The first question is about masking, and I grouped the questions based on masks and then immunity. So the first question is on masking, and this is for Dr. Johnson and anyone else. So masking in Delta variant, is it as effective as with other variants? Number one. The second question was by Dr. Sanati about developmental skills in children and masking. Will the children have changes in developmental skills? So Dr. Johnson, can you take that question for us?
Sure. Happy to take the questions. First, in terms of masking, yes, the masking is highly effective against the Delta variant. The only thing I could say is that the Delta variant is twice as contagious, statistically speaking. So it means then that you probably need to wear your mask, make sure that it fits a little bit better, because you need less virus to spread. But it certainly is highly effective. And so you can feel confident with wearing a mask. That you're going to protect yourself against Delta. The question about development is a very interesting one, and one that I think the jury is still a bit out on. We do know that children, particularly young children, learn a great deal from seeing social cues associated with people's faces, and so there's a great deal of concern about whether or not there's going to be a developmental impact on children as a result of not being able to see full facial features in individuals who are masked. I think what it shows us is that it's important to try and ensure that they do get exposure to other children. I think the outcome is that children's brains and minds are very plastic, and so they're bound to just learn the other cues that they need to pick up on. But the jury's out in terms of what's going to be the developmental impact of being around so many people who have been masked for such a long period of time. I don't know, Allison, if you've read anything different or additional at this time.
Yeah, I haven't read anything particularly different, but it's balanced by the benefits to the slightly older children of being in school and getting their social emotional development supported. So again, none of these risks is happening in a vacuum.
So the other question was about in bands, kids in bands who play wind instruments and brass instruments, because some of these children under 12 are not vaccinated to start early. Any comments on that?
Sure. This has been a major question that's been asked in settings where I'm talking to schools around how to handle instruments. And the first is that it does depend to a certain extent on what instrument you're talking about. For example, the tuba actually generates the same amount of aerosol as talking. And so very little risk there in terms of playing the tuba. But play a trumpet, trombone, saxophone, and all of those present higher generation of aerosol compared to speaking. So at this point, I would recommend that for schools that they move their band outside for individuals who are not vaccinated. So that way there's less risk and you spread kids out by moving them outside. So schools are being encouraged to use instruments that you don't have to blow through. So that way you can continue to have music for kids and music appreciation. But if you're going to use a recorder you're going to use most of the brass instruments, then move that outside. And once the weather gets bad, well, then you're going to have to actually stop the use of those instruments, because just covering where this, the bell of the instrument doesn't accomplish the task, because of course, plenty of aerosol is coming out of the holes. And so unfortunately, in that situation for right now, until we get kids vaccinated to a high level, you're just going to have to stay away from those kinds of instruments.
One of the other questions was about if vaccine, the Delta virus being much more transmissible, wasn't the previous data based on the other variants, not Delta variant, for as far as distancing and spread. So is in the 15-minute rule for other viruses. So does a Delta fundamentally change that 15-minute rule of contact spread in schools?
Allison, you want to handle that one?
Yeah, I don't think it really appreciably does. And I mean, the 15 minutes is an arbitrary cutoff. If you were in a classroom with someone and half of the class is unmasked, it's not 15 minutes, it's 8 hours. So I think it's really splitting hairs.
Yeah, I agree with that. The thing is, the rapid transmission of Delta variant in adults is based on unvaccinated people who are exposed. It doesn't take a very long time if you have 2 unvaccinated people and there's Delta virus. But if people are vaccinated or masked, it really does prevent spread fairly effectively. There were other questions about T-cell the duration of booster doses, Katie. They're talking about 8 months from the second dose. What's the basis for that? Should it be shorter? Because Israelis, you have breakthroughs at 6 weeks, you have breakthroughs that occur a little bit after that. So Katie, can you take that question?
Yeah, so they looked at 6 months and 8 months for the Pfizer vaccine on what was the best boost of antibody titers and neutralizing antibodies. And actually 8 months was better than 6 months. And that's why they picked that. It was not based on data on hospitalizations and incidence of illnesses, because I think we just don't have enough of that data available. So we're still on the in vitro kind of task until we have more worldwide data to be able to tell us how long the vaccines last.
Do we have an acceptable correlative immunity?
No, we don't. And that's the problem. We don't have a titer that we can say, and that would make things so much easier. What titer of antibodies do we need that's protective? We don't have that.
And there's a question about antibody responses, T-cell responses, and how long does T-cell immunity persist versus the IgG antibody immunity? Any data on that are out there?
So we do know with the third dose that you do get more B cells and you get more T cells. We don't know if someone is exposed and then measuring titers after that to see how long does it take for the B cell response to occur, or how long does it take for increasing gamma interferon release after someone's been exposed again. We don't have that data. No, those are incredibly expensive studies and no one has done those.
There is a comment about natural infection producing a more robust antibody response in comparison to 2 mRNA vaccines. I don't think that's accurate. A natural infection does not produce a more robust response, but a natural infection combined with a vaccination produces what's called hybrid immunity. So can you just go over that concept so all the physicians are clear on that?
Yeah, so if someone has had a vaccine or has had an active infection and they get an mRNA vaccine, their titers are much higher than someone who has gotten 2 mRNA vaccines, and much, much higher than someone who's gotten 2 adenovirus vaccines. So we do know, again, their antibody titers are higher. Does that correlate to better immunity? We still don't know. We don't know what that titer is, but we assume that it's more protective.
One of the misconceptions out there that's rampant, including a lot of the physicians, is that natural immunity is superior to vaccine immunity. Can Dr. Johnson or anyone else can comment on that? Is that a true statement? Natural immunity is better than vaccine immunity?
Well, I wish that it was,
We all
but it doesn't appear to be. And this is based on real world data that shows that depending on the variant you're talking about, that generally speaking, either natural immunity and vaccine immunity are equivalent, or vaccine immunity is better than natural immunity that arises from actual infection. Dr. Mullen, Kate has really said it well, that if you have had a natural infection and then you get vaccinated, you get a much more robust and broad immune response. And so in some ways that appears to be the best thing that you can do. The problem is that we don't know where the level of immunity meets antibody level. So that's such an open question at this point.
So I'd like to thank everyone for participating. Dr. Butt, who is the president of the Medical Society, has a few closing remarks.
Thank you, Dr. Chandi. I just want to thank everybody who joined us, and thank you, the panel. Our COVID-19 task force, I like to thank you because you have been doing an amazing job working as safety consultants, making sure our children return to school safely and securely, and the timely and relevant information you have been providing is just phenomenal. So thank you so much for doing that, and thank you everybody for joining us.
I'd especially like to thank Allison for taking time out of her day to do this. So thank you very much. And we will answer the rest of these questions, and have a good night. Thank you, Katie. Thank you.